So I think first and foremost, for those of you that may know me, my whole career has been really around how do we work together across disciplines to help patients. And again, just highlighting hopefully what you'll learn from today is the opportunity space, that this is kind of a clean canvas for Histotripsy of not, again, where we're competing with technology, but where we complement them and where we can help to fill in gaps where today there are current limitations. This is not a new company. So what you've all invested in is something that has been vetted extensively over almost 25 years now. The key take home of what's exciting, I think, for this company and why I decided to join is there is a clear commitment from the CEO all the way through the whole organization to do research. And that's unique for a technology company. But just to kind of just walk through the whole process here, we just received de novo grant from the FDA for liver treatment. And we're currently have kidney and pancreas trials that are ongoing that I'll touch on. So what is a technology that delivers what we call Histotripsy? The technology is called Edison. This is, again, what you'll be getting in March. At a very high level, what's unique about it is, first of all, it has wheels. This is a generator where you can create very high voltage flows through this robotic arm into what we call the transducer. Think of this as kind of a lamp, and within that lamp, there's multiple small lights, which we call essentially ultrasound crystals. And those crystals are activated by voltage, creates a very high pressure that goes through this water bath, through a patented membrane, and non-invasively through the patient's body to a single iso center. And then it activates water vapors to create these bubbles. And those bubbles rapidly expand and contract and create what's called a bubble cloud. And that bubble cloud is what destroys tumors in a non-invasively in terms of going through the patient's body. In addition to that, we have this touchscreen display. There's actually what we call a space mouse that allows the doctor and or users to control this robotic arm with extreme precision. And then right gear that goes, it's within this water bath. It then goes against the patient's body. And that allows you to then visualize on the screen the anatomy. And then that can be fused with CT, PET, MR, or other imaging to be able to help not only target the tumor, but also to then visualize the therapy, as I'll show you. So again, this just shows you this sits on the patient's body. It does have an arm, so it's not that we're not putting a weight on the patient's body. We are controlling that, so obviously they're comfortable. But also what's unique is that when the bubble cloud goes across vessels or ducts, vessels and ducts were more tightly packed with a stronger extracellular matrices, and they had less water vapor within them. So the bubble cloud doesn't form within those structures, and therefore they don't get destroyed. Now, again, it does destroy cells inside and outside of those structures, so the intimal layer can be damaged. But again, because it's a mechanical effect, those vessels and ducts are able to regenerate some of those layers, and they're not damaged. So here's just another view of you would see the cavitation that's created, the treatment volume, but then you can also see the preservation of the vessels going through the contrast enhanced ultrasound of the liver. But going beyond that is that you can also see it in a microscopic way. So again, it's not only on imaging, but microscopically, this is again a porcine liver. And inside, you can see that there's no basically it's all subcellular now. It's been destroyed in a homogeneous fashion. But also at a microscopic level, you could see preservation of the hepatocytes. The reason this is important is it also highlights the mechanism of which involution occurs. So again, if a tumor is destroyed over time, this is a cavity that the normal liver can then grow into and regenerate and replace. So unlike other liver-directed therapies, this allows that regeneration. So how is it actually delivered? How is it done? The physician can download imaging into what we call this treatment planning tool. This planning tool allows you to then simulate what's the optimal position. So we have different size transducers depending on the depth that you're trying to get to. So you select the transducer, you optimize the positioning of the patient, whether you want to do lateral decubitus, prone, etc. And then you're able to then simulate what's the right position to have this transducer to optimize ultrasound energy going through the patient, but also you want to try to limit the amount of things that are going to block the effusive pathway. So ribs, air, things like that. Again, if we can go through those and we could treat, the more that we can limit that acoustic blockage, the better penetration of that energy, the better production of the bubble cloud. And also, that's going to decrease the time of treatment. So again, the physician would identify where they're going to treat. They would put the patient on the table, have the water bath, drop the transducer in, drop the probe to see where you are, and then you can fuse it with other DICOM imaging, put a volume around what you're going to treat. You then do what's called test pulses. So you're going to do a small little bubble cloud at different parts of this volume to make sure that you can cover it homogeneously. And then finally, you're going to treat and monitor. Here's just an example of one that was done at baseline. You could see the tumor, you could see the volume, you could see that the tumor was covering that vessel. But over time, the vessel recovers, the involution occurs, and you get that regeneration around that structure. Why is this important? It's important because, again, if we think about patients who are going to require treatment over and over again, whether it's HCC, colorectal, or even other cancers that we treat today, a lot of times we're limited by, we don't want to cause liver function elevation that can prohibit getting systemic or immune therapy down the road. We don't want to cause toxicities that, again, are going to affect the ability to get systemic therapy. So we want to do everything we can to limit those effects and allow the patient to be treated over and over again, so that even if we can't cure them, they can have a better quality of life and a longer trajectory at a minute. So as we pull this together, when you think about the potential opportunities to use this technology, it's really that we could treat tumors in a decisive way. We can alter maybe the tumor microenvironment or immune system to be an adjunct to other therapies, but also the speed at which it works. Again, because it's mechanical, what we're seeing is that it works fast. So if patients come in with pain, you're getting that immediate destruction, and patients are going home the same day or the next day. But also, most of the time, we're not holding any systemic therapy. Patients are just getting this done during a week off of their systemic therapy, and they're going back on systemic therapy right away. So as a company, what's the roadmap? And, again, most of the focus, understandably, is in liver. We did receive FDA approval in October of last year. We've really only been doing this for a year in a commercial setting. We just finished our feasibility first-in-man study at kidney that was called CANE. We are ongoing at 15 centers with our kidney trial. We treat our first 3 patients at pancreas, and then finally we're moving into prostate, thyroid, CNS, and other areas. I know people always want to know, this is great, but what's the data? How much data do we have to justify the value proposition of this technology? And to be transparent, it's not a lot yet, but again, I think as we'll get into it, we have this, but also we have 800 patients that I'll get into that we're collecting, and then obviously in the viewing box. So we are collecting a lot of data over a very short time. This is the study that led to getting FDA approval for the technology. It was studies, these are patients that had 3 centimeter tumors or smaller, peripheral, had less than 3 tumors. They were treated both in the UK as well as the EU and in the US. We were able to treat multiple different tumor types, not just colorectal HCC. And regardless of what the tumor type was, we were able to show consistent destruction. Overall, the take-home year, and it was a successful trial. It showed 95% technical success, and that's pretty impressive considering a lot of these folks have never used it, many of which haven't actually used this, used ultrasound from that perspective. I think also people then ask, well, that's great because that's like immediate imaging. What about imaging a year or 2 out? So we are continuing to follow all the patients on this study, and we submitted a publication where we look at 1-year follow-up, and the results are favorable, and I would say just consistent with what we typically see with other liver-directed therapies. I think what's exciting about this is that we're going well beyond what we did in our trial. We are treating more central tumors, larger tumors, recurrent tumors. I think the other thing just to highlight is in the trial that I showed you, the Oprah liver study, we mainly treated tumors that were below the ribs, but now you can see in this, you could see that we're able to treat now across multiple areas of the liver. And a lot of this has really been, learned by our users. So surgeons know how to break the table. IR docs know how to use things called jet ventilation. We've looked at different ways to use anesthesia to maximize breathing control and maybe even decrease the amount of lung in the field. So without getting into too much detail, we've really learned a lot over the last year. And we have a monthly peer-to-peer meeting among all of our users where we share best practices and are very transparent about the pros and the cons of the technology. So to just run through a couple of these real quick, these are the areas that we had learned from our different centers of where they'd use this technology. Again, just at a high level, I'm going to get into some of these, but as a bridge or conversion and transplant, as a way to downsize or maybe even decrease the number of surgeries. We can treat central tumors. We treat it in areas that it recur after Y9 Europe, after other treatments, as long as patients get prophylactic antibiotics. And then what's also unique is that we're always sort of stuck with the decision of treating somebody or anticoagulating them because of the risk. One thing we didn't expect is that physicians have not held anticoagulation across the board, if we have not had bleeding. And in fact, we typically give heparin in certain circumstances to prevent any coagulation of the therapy if we have not had a bleeding event, at least to our knowledge, that was recorded by our centers. There's so much exciting opportunity to think about how we can further confine this. we do have a very robust investigator-initiated program. So one, for example, is an HCC looking at combo with acute therapy. And then finally, one that's really exciting is that, a lot of patients who were historically maybe hospice or didn't have many options, like bile ducts that are obstructed, that where patients just can't get therapy, where we can relieve that obstruction non-invasively, or in other circumstances where the patient wants to get on the transplant list, but again, their bilirubin is too high, and again, they're having issues getting on any kind of therapy. How can you help them? Again, just to go through a couple examples for hepatocellular carcinoma. One example is a bridge transplant. This was a case that was done at Cleveland Clinic. This was part of a case that's been submitted for publication. This patient could have probably received any therapy as a bridge. It's peripheral, it could be ablation, etc. Patient opted to do histotripsy as part of an in-house protocol. At Cleveland Clinic, they have a protocol to evaluate different bridge treatments. In this, you could see the liver that was removed. You could see that histologically, there was no evidence of tumor left behind a transplant liver. So again, this gives you confidence that at least you know that you're getting complete destruction of the tumor. Also, we were excited to learn that the UNOS added us as an option for patients on the wait list. And I think, again, this really just speaks to our ability to have a less invasive option for these patients who we know have a lot of comorbidities and it's challenging to treat them. So switching gears to neuroendocrine cancers, as we know, these patients ultimately have a lot of tumors. It can be an indolent a situation, especially in lower grade tumors, where they get lots and lots of therapies and a lot of treatment-related morbidities associated with those. And then a lot of them have carcinoid syndromes to go with it, and then they have to take medications, etc. So a number of our centers actually specialize in neuroendocrine. And this is one case where at Omega, they treated one tumor out of many. And in that, they were able to see that the serotonin went down by greater than 50%. The symptoms improved where they no longer needed octreotide rescue. And it's actually been durable. We talked with the surgeon who treated this patient, and I think it's about 6 months out and still has not required additional treatment or rescue. And now moving on to metastatic colorectal cancer. And this is a case where typical situation, patients had lots of therapies, continues to have recurrence, has been on second, third line therapies, and now has these 3 lesions that have presented themselves, was able to successfully target 2 of them. And this is a non-contrast. This is just showing you, again, if you look at the pre-treatment, the physician targeted these. This was higher up in the dome and realized this was a little bit tougher to get to, so opted just to treat 2 first. And then here, you could see that 1 month post, you could see that there was already some response. Another common scenario is after a Whipple or with a pancreatic stent in place, these patients develop progression. And we're always worried about causing an abscess or inhibiting their ability to get on systemic therapy. So this is a case where the patient, unfortunately has a solitary recurrence. But in this case, the patient was able to get histotripsy and had immediate response, had literally woke up without pain. You could see here immediate post-histo. You could see the response on axial, and then also in the coronal setting. Doesn't match up perfectly, but close. And then you can see here 6 weeks later, there was significant involution. And this patient was able to start systemic therapy 2 days after the treatment and has continued on systemic therapy and has not had any further progression. So, where are we now? We have our post-market study that is now open at several of our centers. We're working to open it to all the centers that are interested. And just at a high level, the idea behind this is that you're treating roughly 10 patients a day now. So we want to learn for every patient that's being treated today. So every patient would be enrolled in this prospective cohort or platform study. And the idea behind this is that we then dig deeper. So we have looked at safety of the first 230 cases. And I'll get to the punchline here. You can see the centers that had submitted this data. This is really the take home that, in general, the complications have been very minimal. Here's an outline, some skin changes. The portal vein thrombosis were all transient and resolved with just heparin on their own. And the patients who passed away here, it was about to be more related to progression of disease and not related to the therapy. So in summary, completely non-invasive. I always say, though, with the caveat that today, these patients are being treated under anesthesia, but we are evaluating, especially partial treatment or palliative treatment, a triaging flow where this could be done outpatient and not have to be under anesthesia. It is a single therapy session, unlike radiation, where a lot of times we have to do multiple fractions. And again, we can preserve vessels and ducts. We can treat multiple tumors in one session. And again, it has the ability to mechanically destroy tumors, open up ideas for other opportunities for, again, immune therapy modulation. And then I think the exciting thing is from a palliative perspective, it does appear to rapidly improve pain, and there's rapid recovery from the treatment, which opens the doors, I think, to be more easily integrated with other therapies. So with that, I will end and appreciate everyone taking the time, and thank you.